Thanks so much, Stu. What a pleasure to join all of you for Synchrony 2020. I was particularly thankful this morning when I woke up with power on. We had a big nor'easter in the region yesterday, and so I was really glad to have power and internet today, highlighting one of the challenges of virtual conferences and telehealth. As Stu said, today I'm going to talk with you a little bit more about characterization and measurement and really reflect on some of the lessons we've learned from telehealth. I will focus much of my talk on some of the neurocognitive measures that haven't been touched on quite as specifically with our earlier presenters. I do receive funding from the Autism Speaks Autism Treatment Network, but don't have any other conflicts or disclosures to share with you today. I hope to be able to cover three main learning objectives to complement the important topics of my fellow presenters. First, we'll talk a little bit about the goals for subject characterization and measurement. We'll also review some of the tools we can use to measure cognitive language and motor skills via remote assessment. And finally, we'll reflect on some of the lessons learned from telehealth and think together about some opportunities that we have really for innovation in the clinical trial world.
Excuse me, Lisa, we cannot see your slides. I don't know if have you shared them on the screen?
I have, yeah, let's try that again. So sorry, let me see if I can fix that for you. Okay.
Here it comes. There we go.
Gracious. All right,
there we go. We're all set now.
Awesome, thanks, Stu. So I talked about some learning objectives, but you can see those there. And of course, we'll share these slides with you so you'll have access to those later on. Certainly let me know if there's any problem seeing slides moving forward.
Great, thanks.
As many of our presenters have discussed already today, we really understand the challenges of remote clinical trial work. So now what? I really see this as a unique moment in history where we have an opportunity to take a few steps backward and really rebuild the way that we approach study design and in particular subject characterization. So as all of you know and may reflect fondly on, the good old days of in-person research visits really allowed us to obtain a comprehensive assessment of cognitive, language, social, and behavioral functions using very well-established tests and procedures. Most of us never questioned this, and innovation in subject characterization was pretty limited. In order to get a geographically diverse sample, we needed to train and monitor lots of boots on the ground. So those of you that are in industry know that you have whole people who are hired to come to us and make sure we're doing everything that you intended in your clinical trial. And all of that requires a tremendous amount of administrative time, effort, and financial resource. So as you know, then COVID-19 hit and we all began to scramble. And as we continue to pave a new path forward, I think it's really important that we do take a few steps back and think about how we want to move forward. As others have talked about, there is an end to COVID at some point in sight, but I don't think that we're going to see the end to telehealth or really this virtual world that we've moved into. So in order to do this effectively, I think we have to ask ourselves why we include a detailed characterization of subjects in our clinical trials. So some of these are obviously quite apparent, but I think it's important to remind ourselves that we're doing these measures in order to establish a well-defined sample and know who we're studying, to control or reduce the variability in our subjects, to ensure proper diagnostic classification for research participation, and to establish sometimes a baseline to which we can compare our outcome measures. Knowing why we're doing each measure that we do as part of our clinical trial allows us to pick measures that effectively balance the benefits of telehealth with the security of in-person assessments. So today you've heard from Drs. Kim and Hendren and Entz about various diagnostic assessments, behavioral assessments, and symptom rating scales. So I'm not going to talk about those things. Instead, I'll focus on the characterization of cognitive language and motor skills during the COVID era, and hopefully beyond. So before we get into the specific tests, I do want us to consider some of the elements that are required for successful virtual testing. Some of our presenters have touched on some of these already, but I think it's important to really remind ourselves that there are a number of factors we need to consider for both examiner and examinee or caregiver success. First, examiners need to be skilled in the use of virtual platform capabilities, including functions like screen share and remote control. I've been doing this since March, and I still failed to share my presentation correctly with you today. So there are lots of glitches that can happen. We also need to be prepared to have spend more time preparing visual supports and paper materials that may need to be sent in advance of a research visit. This does change the way our research staff and study teams are preparing for visits, right? Normally we prepare those papers in the clinic. We can do that the day before, the day of. This would change how we have to prepare for those visits. And finally, examiners need to stay up to date with professional guidelines and recommendations for this new and changing virtual landscape. Subjects and caregivers, on the other hand, need to have access to high quality technology. And for direct assessment, different than other potential research measurement, this would include things like a full-size computer screen and something that a computer that's up to date in terms of its sort of visual and audio technologies. Folks also have to have reliable and consistent internet connectivity, and the ability to complete testing in a relatively quiet and distraction-free environment. Finally, and probably most challenging, we need to make sure that we are providing specific instruction and support to prepare parents and caregivers on how to support a subject or their child during a research visit or during virtual testing. Normally, an examiner controls all of these things themselves in the office, and telehealth has really pushed us to figure out how to more effectively partner with parents and caregivers who are now such an instrumental part of successful testing sessions, or in the case of clinical trials, data collection. Conducting valid virtual assessments require a really clear understanding of the interplay between a number of complex issues, and fortunately, test publishers have acted quickly to provide some guidance on virtual assessment procedures. For example, the test publisher Pearson has encouraged examiners to address elements in a 5-factor model that was adapted from a 2013 paper. I will note and have some references at the end that it is reassuring to me to see that people have been looking into and researching and describing virtual evaluation procedures much before the pandemic. It's just now come into our everyday practice. So this 5-factor model includes attention to environment and equipment factors, assessment procedures and materials, some of the examinee and examiner specific considerations as we discussed on our previous slide. And although we're not going to review all of these in detail today, it is important for folks that have been to know that we've been researching and looking for guidance on telehealth practice long before COVID-19. So take some comfort in that. I included a picture here just to sort of demonstrate one of the ways that we have to pivot is in terms of our physical materials. So for more complex testing, we're using different behavioral supports to help elicit the most valid data from our subjects or our patients in the clinic. And in normal times, I took a picture of the star chart that's on my desk at the office that I haven't used in months, and show you a screenshot down below of something that we've adapted, really simple visual schedules that can be used for people as you're completing virtual assessments with them. But all of these are things we hadn't thought about before COVID. So now to get into some of the nitty-gritty, dive into the specifics. Almost every clinical trial in the ASD or IDD realm includes some characterization of cognitive skills or IQ. We do this to understand who is in the sample and generally to rule out very severe or profound intellectual disability that would cloud our autism diagnosis. Fortunately, we have a fair number of options for virtual administration. So tests like the Wechsler scales, the WISC or the WASI can largely be administered virtually. The Stanford-Binet, which is extensively used in ASD and IDD research, can also be administered virtually for subjects who are older than age 7, although more delayed populations would need potentially to drop down to in-person use of manipulatives. And when direct assessments with manipulatives is not feasible, we found that an interview-based cognitive assessment like the Developmental Profile 4 or DP4 is a really helpful option. I'll tell you, this tool has actually changed pretty significantly our clinical practice and is now part of every single one of our autism diagnostic evaluations. We found that it really nicely captures emerging global cognitive skills through a parent interview, and in fact, probably provides more accurate data than using an upward extension of tools like the Mullen or Bailey for older subjects with significant cognitive impairment. So for those of you who have been involved in clinical trial characterization for a long time, studies are often designed with a primary cognitive, and then if folks cannot complete a valid score, obtain a valid score on that measure, the study often has sort of a second procedure that can be put in place to establish an age equivalent of cognitive skills, again, in an effort to rule out some of those more severe or profound intellectual disabilities. And I would argue, after years of doing things like the Mullen with research subjects in clinic, that probably the developmental profile interview form provides a more accurate picture of cognitive skills than asking, let's say, a 12 or 13-year-old who has significant intellectual disability to complete a play-based measure that's designed for toddlers. So I really appreciate the use of this tool. So all of that is good news. Unfortunately, as Dr. Ventola mentioned at the start of our session today, we don't yet have extensive equivalency studies on all of these direct assessment procedures, but the early data does suggest pretty good equivalency for cognitive tools. For example, a paper that was published just this summer by Dr. Wright at NYU showed nice equivalency across virtual and in-person administrations of the WISC-5. Clinically, I feel pretty confident that we're going to see more reassuring equivalency data, but as Pam said, we just don't have the data yet. Direct assessment of language skills via remote administration is a little bit more straightforward. We do have plenty of tools that work quite well for virtual assessment of language skills to measure things like vocabulary, language comprehension, and communication. One real quick sort of real life research example from a study that we're currently involved in. Back in March, one of our clinical drug trials was ready to begin recruitment pretty much at the exact same time as our stay-at-home orders were set into place. Yet the biggest obstacle that we faced is that the primary outcome measure for the study was direct assessment with the self, the clinical evaluation of language fundamentals. It became clear that we needed to pivot quickly or the study would be dead in water. And good news, we have been successful at transitioning to virtual assessment. We did have to make some important changes to make sure that both examiners and subjects were ready for virtual administration. And we also made the decision that any subject who started the study with a virtual self would need to complete a virtual self at the endpoint. Just a week or so ago, I was able to see one of our first enrolled subjects for his final visit. And although he was now in the clinic, because we are back open in the Boston area for select visits, we completed the self via Zoom in the clinic in order to reduce some of the variability in the mode of administration of that important outcome measure. I just want to make a quick note. Someone had asked earlier about changing from virtual to in-person. And until we have data that shows otherwise, I would strongly recommend that folks maintain the same assessment format in order to reduce variability in measurement. And again, I can't move on to our next slide without just highlighting yet again that although all of this information is promising, we still need to see the equivalency data for virtual use of all of these tools. In terms of motor skills, direct assessment of motor skills as well as caregiver report is possible via remote administration. These tools do require a bit more preparation in advance, as in some cases like the VMI or the NEPSI visual motor precision tasks, materials do need to be sent to subjects in advance. In addition, I do want to mention that this is really one exciting avenue for improved technological advances. At Mass General, we're actually working with our colleagues at Mass Institute of Technology, or MIT, to develop a virtual or iPad-administered fine motor assessment. And I think we're going to see more innovation in this realm as we move through the pandemic and into sort of the new age of virtual work. So what do we do now? We have a lot of promising tools. There are a lot of things that I believe we can successfully administer via remote assessment. But what do we do? How do we move forward? Well, the most important thing I would tell you is that it's really important to make sure you have an experienced and probably innovative researcher neuropsychologist on your team. Within my field of neuropsychology, there have been significant differences in how quickly folks have felt comfortable with virtual assessment and to what degree folks are really using virtual modalities in order to continue their work. So you will hear from others who may have a different message than I'm sharing with you today. But if you're looking to move your clinical trial work into the virtual world, you're going to want to make sure you have somebody on your team who's willing to think creatively with you about how we move things forward. You also want to make sure that you think about your goals for characterization and measurement and your options for remote administration at the same time. And I'd also recommend doing this really early in your planning phase. By considering how each instrument and data point will fit into your data analysis plan and your reporting from the start, you can select instruments that give you the data that you need in the format that works for your trial. So as I wrap up my talk for today, I want to speak briefly about some of the big picture lessons we've learned about characterization and measurement during telehealth and COVID-19. First and foremost, we've learned that we have to go back to basics and really start to question what we're doing and why we're doing it. So instead of just doing what we've always done, we've been forced to ask ourselves, what is the goal of testing? Are there reasonable virtual alternatives? Is technology available and accessible? And how much of our trial can convert to a virtual model? There are lots of challenges with all of this. And I think that, I don't want to understate, as I highlight what I see as great possibility for innovation, that there are some challenges and still work to be done to really fully move us into a virtual future. At the end of the day, the field of medicine has been thrust very quickly into a telehealth world, and it's unlikely, in my opinion, that we'll ever see a full return to baseline. I believe there are simply too many advantages to telehealth. And I think, as Pam mentioned earlier, and I think Dr. Neumeier as well, I think parents will continue to ask for this, whether we want to go back to in-person or not. And so I anticipate that we'll continue to see virtual research appointments as part of our clinical trials moving forward. For this reason, I challenge us to think really thoughtfully about the lessons we've learned and consider this as an opportunity for innovation and research. I wonder if we can see a clinical trial landscape where we have fewer sites, but greater geographical reach and recruitment. Would this allow us to allocate resources to innovation as opposed to administrative costs and burden? On the other hand, will we see new burdens arise from telehealth? I also wonder if this would improve the efficiency of training and site visits and monitoring, and potentially even reduce some of the variability in data collection that happens across sites. Certainly, there are very obvious gaps in the evidence to show that virtual data collection is equivalent to in-person. Yet, I suppose in the midst of 2020, I'm still an optimist. I do think we have work to do, but I think that now really is the time for innovation. As I wrap up my talk, I do want to just highlight briefly that we can't be naive to some of the challenges that lie ahead of us. For example, licensing laws have not fully caught up with the world of telehealth. This may be less of an issue for psychometric testing, but medication prescribing may present a difficult hurdle. This is something we're facing in New England, where smaller states are much closer together. We often care for and recruit samples of patients from states all surrounding the Massachusetts and Boston area. And so this is something where the laws have simply not caught up with our clinical and research practices. We also need to push test publishers to update tests and normative data specifically for virtual administration and telehealth use. This is something they are working diligently to do and have really done a tremendous job, in my opinion, in sharing information, offering guidelines and recommendations for using these tools in a virtual format. And as I mentioned earlier, we're still missing the equivalency and validation data to demonstrate the effectiveness of virtual administrations. Finally, I would be remiss if I didn't highlight that access to technology or lack thereof continues to reflect a pretty significant healthcare discrepancy that's a real issue in research. And things such as general mistrust of medical institutions, time away from work, and limited access to technology are all issues that we need to be mindful of. And we need to be incredibly cautious that we don't inadvertently increase some of these disparities in our research as we try to take advantage of telehealth. I've included on the next slide a number of references, some dating back many, many years, and some much more recent, really to highlight for you that folks have been looking at telehealth and virtual administration of psychological assessment measures for many years. And I hope that these are both helpful for you and potentially spark more questions and conversations. So thank you so much for letting me join the conversation today. And I would be happy to take some questions if we have time for that.
Thank you very much, Dr. Nowinski. That was terrific. I think there's a lot there that we need to think about, which you've highlighted very nicely. Equivalency testing being one of the really critical factors. And so we have a couple of questions here and we have a few minutes. So will we need to wait until after COVID to execute the appropriate equivalency trials? I guess I think where that's coming from is, if we go back to, you say we may not get all the way back to baseline, but do we have to wait until that, whatever the new baseline is, to create the environment to do the right kind of equivalency testing?
Yeah, I think that's a great question. And honestly, the answer is no. So the equivalency paper that came out just this summer on the WISC-5, for example, was published very quickly. And when you look at that, they're really starting some of that research with data that has already been collected on in-person administration of these assessment tools. So I believe we have the in-person data, not me personally, although we actually have a fair amount in our clinical work. So if we could find ways to fund time to pull that out of our clinical medical records, we really could have the data very quickly. We're also, we now have 6 months or more of virtual administration data. So in some ways, I think, at least from my perspective, the challenge is going to be finding the time and sort of effort to pull those tools out and do the validation. But I think the data, we won't have to wait until we can go back in person in order to do that work.
That's great to hear. So another question was, has construct validity been established for these cognitive assessments in the subtype of non-speaking kids or people with autism with significant motor challenges? So those who say can't handwrite.
No, you're asking a really important question. I think that honestly speaks to a bigger issue related to measurement and characterization, both in the clinical and research realm for autism spectrum disorders. The vast majority of our tools are not designed for some of the more unique populations that fall in that autism spectrum umbrella. Clinically, there are lots of things that we do, including modified assessment procedures and testing the limits in order to make sure we get a really good clinical picture. In research, it's a bit more difficult because we are making an effort to standardize our data collection in ways that may actually make it difficult for some individuals who fall potentially at the more fringe or complex profiles under the autism spectrum umbrella. Makes it difficult for them to participate in measures that are not designed specifically for them.
So do you think, if that's the case, that in those situations, would those people maybe be excluded from a clinical trial, or would there be sort of a composite way to assess them using other tools?
Yeah, I think it's a good question, and it really pushes me to sort of push our conversation back to why we're doing a particular assessment procedure and what is the point of that specific characterization. So taking cognitive or IQ assessment, for example, usually that's not designed as an outcome measure, right? That's something we're using to characterize at baseline or at our screen visit because we want to understand the sample, and usually because we want to rule out a specific, very severely impaired population that would make our research more complex or cloudy. And so if that's the case, I think there are ways to set up your inclusion and exclusion criteria to try to allow as broad of a sample, right? So that we can include patients, for example, with a significant motor challenges in a sample and still have a reasonable estimate of cognitive skills. This is a place where I think we haven't yet fully tapped some of the interview-based assessment of cognitive skills like the DP4. This is a tool that clinically I've been using much more extensively. I just used with some siblings that I tested last month, for whom, for various reasons, including motor skills and significant autism spectrum symptoms, have difficulty demonstrating their underlying capacity on standardized testing. And I think the interview form really allowed us to capture in a more realistic way where their cognitive skills truly fall.
Okay, no, that's actually really, really good. So I think that's a really great point that sometimes in research we kind of lose sight of, is why are we using certain assessments? Yeah. And it's a classic thing in any kind of experimental design, is you get fixated on a certain way of doing something and then you forget to keep asking yourself why. And I think it's important to take those steps back and really assess why.
Absolutely. And I think this is a piece we didn't have a chance to talk in person with Dr. Kim about, but I think this is a piece that's very relevant and Whitney touched on in her presentation for us to reevaluate diagnostic assessment procedures like the ADOS. That's included as entry criteria for almost every clinical trial, budget allowing, and it is a tremendous obstacle for some sites and for some clinical trials to sort of get off the ground if that's what's required. And so I think this approach of sort of stepping back and really reevaluating why we're doing what we're doing and if there are alternatives that may have benefit for the trials overall.